We are live. Dr. Madhvi.
Yeah. Hello, everyone. A very good morning to all of you. On behalf of AIOS, I'm delighted to welcome you all to the 17th episode of the AIOS Guru Sangam. This is a novel and unique platform for teachers to showcase their teaching talent and one of its kind platform to enrich the knowledge of our resident and fellow doctors in various ophthalmic subspecialties. As the saying goes, wherever you find something extraordinary, you'll find the fingerprints of a great teacher. Keeping this in mind, AIOS has created this unique platform to bring together teachers from all over the country and make their teaching skills available to students in every corner of India and probably over the world as well. I am your moderator and host for today, Dr. Madhavi Bijlani. I'm a neuro-ophthalmologist practicing in Mumbai and Pune. Our episode today will focus on neuro-ophthalmology as a subspecialty, which is a mystery and a curiosity by itself, I would say. So, before we start today's session, I would like to acknowledge and express my gratitude to Dr. Samar Kumar Basak, the president of AIOS, who has given us an opportunity to create Guru Sangam, and the directors of this innovative program, whose brainchild is Guru Sangam, Dr. Santosh Honawar and Dr. Manoj Mathur, sir. We also have with us today our teachers and consultants on the expert panel joining us from across the nation to give a thorough and complete overview of the subject of neuro-ophthalmology. Our panel today includes Dr. Digvijay Singh, who is the Director of Noble Eye Care with various centers across Delhi and Gurgaon, Dr. Jawaharlal Goyal, Senior Ophthalmologist at Sharda Hospital, Noida, Dr. Rashmin Gandhi, Senior Consultant Neuro-Ophthalmologist at Center for Sight, Hyderabad, and Adjunct Faculty at IIT Madras and IIT Hyderabad. Dr. Shikha Basi, who is the Deputy Director of Neuro-Ophthalmology Services at Shankar Netralaya, Chennai. We also have Dr. Swati Fuljele, who is the Additional Professor in Department of Strabismus and Neuro-Ophthalmology at RP Center, AIMS, and Dr. Virendra Sachdev, who is the head at GMR Varalakshmi Campus and consultant ophthalmologist at LVPI Vishakhapatnam. A very warm welcome to all the panelists. We are looking forward to your inputs and expertise. Let's jump right into our episode with today's first speaker, Dr. Meenakshi Yadav Dhar. Dr. Meenakshi, could you please share your slide, your screen, please? Dr. Meenakshi will be talking to us today about the role of OCT in neuro-ophthalmology. Let me introduce Dr. Meenakshi Dhar. Ma'am is the head of a professor and head of ophthalmology at the Amrita Institute of Medical Sciences at Faridabad. She has been a part of the Amrita Institute for over 25 years, working at Kochi earlier and now at Faridabad. She is a pan-ophthalmologist and her interests include OCT, visual fields, multiple sclerosis, and of course, neuro-ophthalmology. She has numerous papers as well as publications to her credit. She is an equally prolific phaco-surgeon and a glaucoma specialist, having done clinical observerships at UCLA and Cambridge in UK. We are indeed privileged to have you with us today. Handing over to Dr. Meenakshi Dhar for OCT in neuro-ophthalmology.
Is it showing?
Yes, ma'am.
Yeah. I'll start. Thank you, Dr. Madhvi, and thank you to Dr. Santosh and the entire team of AIOS. Coming to OCT in neuro-ophthalmology, it is now well established and it is being used. One should not interchange the readings from different machines. And the spectral domain OCT is what I will be focusing on, not that there are no financial interests. It's just that I've been using the time domain first and the spectral domain now of this kind for the last 2 decades. The spectral domain OCT has a better and higher resolution. One can also do the ganglion cell layer analysis. It is less operator dependent and automatically centers on the optic disc. The STOCT allows us to have a quantification of the retinal individual layers, and it also giving a high correlation with the perimetry. It's predictive of the future progression, and it's highly sensitive and specific of several neuro-ophthalmological entities. While one is reading this printout, one should remember that one has a look at the patient data, the signal strength, and go methodically over it. A low signal strength still gives a OCT analysis, so one should not analyze printouts with lower RNFL thickness, and because it will with low signal strength, because it gives a lower RNFL thickness values. Even blinking in our movement artifacts can affect it, and also the scan alignment, as can be seen here. If it is higher, it interprets as the reading as thickness as 0 there. So one should be careful that one is reading a good printout. When we are doing this, can you give me a minute? It is interfering with my... Okay, I'm not able to minimize the speakers on the side.
It's okay, ma'am. It's visible. You can just click on the screen and start.
Okay. So when we are scanning the macular GCC, because it's coming in the way of my slide is what I was thinking. If I can take this down somehow.
Just click on it and drag. Or you can, there is a minus sign, you can just minimize that. Just click, hold and drag.
That's all, messing it up. Never mind. Now, scanning of the macular ganglion cell layer is important because 50% of the ganglion cells are in the macula, but it includes the IPL and the ganglion cell bodies, but excludes the NFL. In the, for instance, in glaucoma, it's the infratemporal sector which is earliest involved. In neuro-ophthalmology, it depends on the various entities, and then it gets involved in various sectors. OCT is a biomarker and it represents a surrogate marker of neuroaxonal integrity in the afferent visual pathway. Neurodegenerative components of the CNS diseases can be captured with this imaging technology. It complements but is not a replacement of the functional visual outcomes. But we see the peripapillary RNFL and the GCC, and these both reflect the axonal injury of the RGC. It is used in optic neuritis, multiple sclerosis, and as well as NMO, in AION, IIH, pituitary tumors, and other cellular lesions, optic atrophy, intracranial tumors, and optic neuropathy due to drug toxicity. The peripapillary RNFL is thickened in optic neuritis, in acute ischemia, and in short-term IIH, while it is thinned down in neurodegenerative diseases, in toxic and nutritional neuropathies, in inflammatory and ischemic processes after the acute phase is over. In multiple sclerosis, optic neuritis presents in 25% of the patients as a presenting event. In acute care stage, it can be confirmed by the presence of the optic disc edema, and after that, there is a severe axonal loss. Detection of subclinical axonal loss can also be seen in patients with normal visual fields and normal visual acuity. Both the RNFL and GCC are inversely correlated with the functional disability score of MS. It correlates well with the contrast sensitivity, color vision, EDSS, and the brain atrophy. The progressive RNFL and GC-IPL thinning can occur by 1.49 and 0.53 microns per year, respectively. So in different types of RRMS, one sees the different patterns. For instance, in RRMS, that is relapsing remitting MS, one can see that there is a decrease in the eye which has optic neuritis, but also there is a decrease in the eye without optic neuritis. And whether it is due to an edema or due to axonal loss is also a question to wonder. And because both the swelling subsides, as well as there is atrophy occurring, so there will be a decline in the RNFL. And on the other hand, the blood vessels and glial elements also contribute to the RNFL. Hence, the GCL damage is a better prognostic indicator and an initial prognostic indicator. And in an acute phase, it may appear as normal. So in a patient with 1 day history, the the OCT will not show anything. The visual fields may show anything. But within a week or two, you will see the GCC changes appearing, the decline occurring. At 6 weeks, the RNFL also starts showing changes. And at 3 months, we can see the full profound effect of that acute optic neuritis attack. The macula and GCL layer thickness is more sensitive to damage, and it is reduced before the RNFL. It is unaffected by acute axonal swelling. It's a structural indicator of therapeutic interventions during the acute stage. And it also predicts the general axonal loss. And it gives a better structural and functional correlation with visual acuity than RNFL in all subtypes. And it is sometimes even, it can be present even in the absence of the symptomatic episodes. And so the sectors which have the highest abnormality are the supranasal and the infranasal. So the macular GCL thickness correlates better with the visual acuity, contrast sensitivity, the visual field mean deviation, disability, as well as the MRI. Another thing seen on the OCT in patients of MS is the small hyporeflective spaces within the INL in the parafoveal area, which is the microcystic macular edema. And this spares the fovea and limited to the INL. MME and INL thickening on OCT can occur in MS, and it's a useful predictor of progression. It is not confined, it is not specific for demyelinating disease and can also be seen in compressive, toxic, nutritional and hereditary optic neuropathies. Also, macular edema can be seen in MS patients, either associated with intermediate uveitis or the fingolimid associated macular edema. It's in different types of MS, there is a different kind of a picture. In the secondary progressive MS, there is more RNFL thinning, and the total macular volumes are also decreased more in the secondary progressive type. The GC-IPL thinning in all types of MS is more prominent in the SPMS. And in progressive MS, inner plexiform atrophy mirrors the brain atrophy. Coming to optic neuromyelitis optica spectrum disorder, here there is greater axonal loss and a poorer visual prognosis. The RNFL changes are seen in the superior and inferior quadrants, and the subclinical RNFL loss is very rare in NMO, is one differentiation one may have from MS. Otherwise, it's difficult to differentiate between the picture on OCT between MS and NMO. In AION, there is visual loss after an episode. It depends on the amount of damage which has occurred. And initially, there is RNFL swelling, which correlates with the severity of atrophy. And the temporal RNFL is decreased by around 40%. And it is seen that as the disease progresses, there could be first at onset, there is RNFL thickening. And then later on, it shows thinning. And at around 6 months, one comes to know what is the total loss from what. Depending on the visual field defect, you can have different areas of RNFL thinning as well. In some patients, there could be also a subretinal fluid, which may contribute to the vision loss, and later visual recovery may occur once the fluid gets reabsorbed. So you may only see thickening earlier, and then you can see the thinning of the RNFL. The giant cell arteritis cupping occurs after ION attack. Optic disc size and new Brooks membrane opening in NION is also being now studied. Coming to the NAION, macula and GCL are also thinner and show stronger correlation with the visual fields than the RNFL parameters. For instance, here we can see that the RNFL is still normal, but there is a severe GCL loss on the left side. Then again, left AION presenting with this edema and maybe it's in the earlier one, in the first week itself, and you cannot see any changes on the GCC. Coming to compressive optic neuropathy, the first use of the OCT, which was being done since a long time now, if you have visual field defect, you have visual loss, and you do the OCT, and the type of recovery depends on number of axons which are left at the time of diagnosis and at the time of treatment. If there are more axons left, there is a higher potential for visual recovery. So if the RNFL is normal, in spite of having visual field defects, the chances of recovery are more. But if there is a thin RNFL, there may be only an insignificant improvement in visual acuity after the neurosurgical intervention, or medical treatment for the same. Also, OCT helps predict the visual for visual field improvement. Here you can see that this patient had severe GCC as well as RNFL loss, so unlikely that this patient would improve. Also, the RNFL changes occur rapidly. Like in this patient, within a month, there was almost more than 10 micron loss. So that tells us that one should intervene early. In a patient of optic chiasma syndrome with biotemporal hemianopia, there is an inforonasal sector thinning, which can be seen with a corresponding visual field defect. Also, in patients with thyroid-associated orbitopathy, there can be OCT changes, and they are reversible if and when treated early. In the patients of IIH, it helps you detect an earlier IIH and confirms if you just have a mild little swelling, and first it appears nasally. It is potentially useful tool for quantifying the degree of papilledema in IIH and monitor the treatment efficacy. The RNFL decreases both with the decreasing edema and the increasing of the optic atrophy. In low grades of papilledema, there is RNFL is increased, but in a severe papilledema, it goes beyond the software algorithm, and that's when one can look at the GCC and see if there is any thinning involved. Total retinal thickness may also help in such patients. In the Nordic trial, it was found that the GCL plus IPL thinning at presentation was correlated with the worse visual acuity, and GCL thickness, when it was equal or normal, led to a better visual acuity. Structural neural loss is not indicative from the RNFL measurements due to swelling. Detection of axonal loss, even while the disc is swollen, can be given by the GCL-IPL thickness. And a normal GCL-IPL thickness during follow-up points to a good prognosis. So here you have the pre and post treatment, and all the GCC was normal and continued to be normal after the recovery. Here, the CC thinning was there, and it continued to be there later. In optic nerve head drusen, OCT can help us. It gives a visible to supratemporal drusen. One can see that there is an RNFL thinning, and OCT distinguishes between a papilledema and pseudopapilledema due to the buried ONH drusen. And here the GCL analysis is useful in detecting the earlier changes, and also autofluorescence and enhanced depth imaging can be useful. On the OCT, one can differentiate between an ONH drusen from papilledema because of its lumpy appearance of the ONH internal contour, while it is smooth in the papilledema. Also, there is a hyporeflective space between sensory retina and RPE, which has an abrupt end. And in contrast, papilledema, there is a recumbent V pattern. The papillary elevation is not greater than 0.8 microns in ONH drusen, while it can be much, much more in papilledema. And in the ONH drusen, the RNFL is not increased for more than 7 clock hours, while it could be for all the clock hours in papilledema. And so this can help us detect an ONHD, and one can see a decrease in the GCC in these patients. Coming to the post-geniculate homonymous seminopias patients, the RNFL may be normal, or in patients with intracranial hemorrhage in the temporal lobe, there could be GCL involvement with the right homonymous hemianopia. Corresponding areas of the changes can be seen in the GCC, which may be earlier than what it appears in the RNFL. In patients of neurofibromatosis, if after a post-schwannoma surgery, one can see the changes in the OCT, which may be reflecting the change with the gross papilledema. In dominant optic atrophy, there is loss of macular retinal ganglion cells, which is the earliest pathological event. And one can see that there is a decrease in the temporal preference of RNFL loss, especially followed by inferior. In Lebers, in acute stage, there could be an increase in the RNFL, and GCC decreases 6 weeks before that. And a GCC can help you discriminate between the fundoscopically normal LHON and the functional ones. And in patients of Alzheimer's, also there is a significant RNFL loss, which is more seen in the superior and inferior quadrants. Patients of Alzheimer's have also been found to have a choroid, macular, and GCL thickness decline. This may actually be used as an early detection method to identify patients with normal cognition who have a high risk of developing this. In patients of Parkinsonism, again, there is a decline in the RNFL and macular thickness, and this decreases markedly. And it may correlate with disease severity and duration, and also the retinal dopaminergic and neurodegeneration. So it can be used as an adjunct to follow patients' the disease progression and efficacy of the neuroprotective treatment in patients. We hope for a better correlation between neurologists who should be sending us each of these patients. Only can this become more useful and successful. Patients of migraine have also been found to have a significant reduction in the temporal RNFL. RNFL is less in patients with a migraine aura, and thinner RNFLs have been found in patients with a history of migraine for over 15 years. In patients of optic neuropathy, which is induced by the ATT, also one can see the changes. This is one of our patients who was a child with a lady with Down syndrome. So it was very difficult to comprehend her and understand her. She had a vision loss, very severe papilledema, and there was almost a 6 diopter hypermetropia at that point of time. Later on, after stopping the ethambutol, one could see that the RNFL came down, and since it was caught early, it did not lead to permanent damage. On the other hand, this young lady of 18 years who had been on ATT came to us with decreased vision. In spite of stopping the ATT and following up the patient for more than 1 year and operating her for incidental cataracts that she had in both eyes, the vision did not improve. Then even linezolid toxicity can present with a decrease in the RNFL and GCC. Although this patient of ours, it was complicated by the fact that the patient also had a history of pituitary tumor, which was operated. This patient did not gain any vision. So we have to remember that we have to keep the clinical scenario in mind and correlate each of these possible entities having to contribute with the GCC as well as the RNFL loss. In nutshell, in neurodegenerative diseases, strong potential to using OCT, especially the GCC, as a biomarker for Alzheimer's and Parkinson's. It can also be used in patients with Huntington's disease, where there is a reduced macular volume and temporal RNFL. The limitations of OCT are that we don't have any references for children. The anatomical variations have to be kept in mind, like in myopia, there is thinning of RNFL either way. Media opacity alter the image quality and hence the reliability. Low image quality can cause erroneous retinal layer detection and segmentation errors, as I've shown before. Patient cooperation and fixation is needed, even if it is finished in a few seconds. Comorbidities like Parkinson's and glaucoma, if they coexist, it will be difficult to discern as to which the damage being due to disease A or B. So we can, OCT can also be used to monitor treatment with neurological, like for instance, in Vega-Betrian, there is irreversible retinopathy and visual field loss. They have a RNFL thinning in the with spading of the nasal quadrant. So OCT has a lot of uses. It is coming in its new advanced forms, which will have a greater scope. And we can utilize this for every patient who comes as a suspected neuro-ophthalmic patient and ensure that we do a RNFL, GCL, as well as a line scan of the macula to understand the disease better and diagnose it better. To conclude, the OCT neuro-ophthalmology evaluates axonal and neuronal integrity. It assesses disease progressions in the afferent visual pathways. It can help you predict visual recovery, especially in pituitary tumors. It's a powerful biomarker of neurodegeneration, and it has a promising future, especially for neuroprotective trials in multiple sclerosis. Thank you for patient hearing.
Thank you so much, ma'am, for that illustrative talk with all the examples. It thoroughly covered the entire topic of OCT in neuro-ophthalmology. I had a few questions which I would like to put up to the panel as well as to you, ma'am, and all the other experts available here. So, when we talk about OCT in the form of RNFL or GCC, especially for toxic optic neuropathy or AKT induced, how often would you say that we need to do a serial OCT to see once we have stopped ethambutol, suppose, for an AKT patient? How often should we monitor it to see whether it is improving or worsening or the same?
Shall I answer, or would Panab like to answer?
So I think Dr. Meenakshi has anyway covered all of that, but we did do some work on the OCT, in toxic neuropathies. So generally, you see, so a lot of times, at least in the beginning, when you want to diagnose it, the functional changes may come before the structural changes. So in that case, you do want to monitor on both, at least have a baseline scan when you're starting them on ATT, if that is possible. But once you have, found toxic optic neuropathy, or you recognize that, and then you stop the ethambutol, most of the times the OCT changes would stabilize over the next 3 months to 6 months at best. Therefore, most of the studies, if you see, are for that duration. However, if there is somebody who is progressively having a decline in vision, I think you can continue to do serial OCTs going forth. But the important thing to remember is the function tends to get a little more importance than the structure in that case.
So we have, since we are in a multi-speciality hospitals, we try and encourage most of our specialities to send us. So many, the pulmo people especially send us, and many wait for the damage to occur and then send us. So we advise that when a patient is being started on the treatment, one should come and get a baseline OCT and HFA done, because there could be coexistent diseases which may affect the later outcome.
Correct.
Like just last week, I had one patient who had a decline on one day after whose RNFL and GCC showed changes, and the patient had been on ATT only for a day. So it is not attributable to the disease. So we know that this patient, when we follow, although she had no functional damage at all, vision and fields were perfectly normal. And once we detect a thing, we normally call them after a month and see if there is a further decline. Like, for instance, some of our patients who are stopped on ethambutol get started on linezolid, which is also being extensively used now. And although in literature says that linezolid is reversible, but of the 6 patients that I've seen with linezolid in the last 2 years, I have not really found that change to be occurring. So things are yet to unfold.
Okay. Yes, ma'am, that about answers my question. I had another question about OCT in kids. I know that's a drawback that we have because of the limited data. But if we create a baseline for the kid itself, for like some pediatric IIH patients, does that help in any way, the RNFL or GCC protocol?
Of course, it helps, because what we do is children, sometimes even 4-year-olds, can do a good OCT, and maybe a fundus picture. They won't cooperate for anything else. Like, we have a lot of patients who are referred by the pediatric neurologist. We have Dr. Sangi with us, who is the lead in pediatric neurology. And so we keep this baseline, and maybe sometimes just for us to understand better, get at that red green thing, we do change the age and take look at that printout, but that's not what we ever give to the patient. And as we follow up the patient, we see whether there are changes, it's increasing or decreasing.
Yes, ma'am. I would also like to ask the panel what their opinion is about a routine OCT in patients with neurodegenerative disorders. Like as ma'am said, we need a lot of collaboration with neurologists for this as well. But should we advocate getting a baseline done for all these patients, or what would you select in your practice? Anyone from the panel would like to add to that?
Yeah, now we are at a
Yes, ma'am.
stage. Right. So when we talk about neurodegenerative diseases, we are talking about Parkinson's, we are talking about Alzheimer's disease.
Alzheimer's.
So in both these diseases, it's been shown that there is a progressive decline in the RNFL thickness. So it kind of correlates with the degeneration that's happening in the brain. So it's one of the biomarkers for diagnosis. It's a non-invasive. Where we're going today is that it's being called the non-invasive and a little cheaper, investigation used as a biomarker to diagnose at least Alzheimer's disease and even in Parkinson. So what we're looking at in these cases is the retinal nerve fiber layer thickness and also the macular volume. So the GCC thickness also. All these three things, they have been shown to be reduced in patients with Alzheimer's. So now completely confirmed diagnosed case of Alzheimer's, it might not be, it might not add that much of value. But those early cases where, there is just early decline in memory, there it's, playing a little bit of...
But what I find as a hurdle in this is that the neurologists and neurosurgeons, although in the same building, have a limiting factor to let the patient reach out to us for this simplistic investigation.
Now, it also depends on the, kind of understanding that you have with if they have the query. If they have the query that, that they want to differentiate between an early Alzheimer's, where there's just an early cognitive decline, and you want to confirm whether it's going towards Alzheimer's, you can do, OCT can definitely play a role in kind of picking up these changes in the retina, which go hand in hand with the changes occurring in the brain. So it's definitely being used as a biomarker for these diseases, and even in Parkinson's, I would say. And it's a time-dependent decline in the thickness.
Yeah, but
Okay,
I feel not just diagnosis, it might as well help in prognosis also. Why? Because over the time we have seen that there are changes that will occur as the disease, specifically this degenerative disease, when they progress, that is reflected in our RNFL layer also. So maybe it may help neurologists in monitoring the disease, where understanding where the treatment that they are giving is effective or not. So probably every 6 months or maybe once a year, that can be done to know whatever is, if the disease is progressing or stabilized. So an indirect way of assessing the progression, I feel. And we have seen that in 2 studies that we have done in Alzheimer's and in Parkinson's. We have seen that, over the time, if it changes, it is an indirect marker.
Okay, so like in an early stage as well as for prognosis, both ways it does play a role in neurodegenerative diseases. Just one more last question I have. Like I asked about the serial OCTs for toxic optic neuropathies, when we are seeing patients with IIH who we are treating actively, where we are studying the edema going down, how often would we want to get an OCT done with them, especially if we are like in a sort of a financially constrained setup, like in a government hospital or patients not affording? What is the minimum time period after which they must get an OCT repeated?
6 weeks.
Anyone from the panel? Yeah, yes, ma'am.
6 weeks, I would say. 4 to 6.
6 weeks.
It depends on how fast, how fulminant the IIH is. See, if you've got a very fulminant disease, it's not only about OCT, it's about in general monitoring of the patient. Monitoring depends on how aggressive the disease is. If the disease is like it just comes and takes away the complete vision, you need to decide fast whether a surgical intervention is required, the ischemia is setting in. So I think the follow-up depends on the kind of disease that you are monitoring. And
So a
at
more
every
tailor-made sort of
at every follow-up, if it's possible, at every
Right.
follow-up, OCT is going to
Get
give
one.
you some information.
Right.
Yeah, I would like to agree there with Dr. Shikha that, it's the type of the disease, whether it's a normal IH or a fulminant IH, where you need to have aggressive treatment. So it's more about treatment than the monitoring on OCT. We also need to keep this in mind that in early stages of IH, if there is too much of disc edema, GCL may give us false thinning, which is a very important thing to keep in mind whenever we are monitoring these patients. So it's more important when your clinical edema has gone down and you want to know whether the patient will gain vision or patient is still showing deterioration in spite of your edema going down. There I think it has much more role to look at the GCL, why vision has not turned out, why vision has not reversed back to normal, or why is it still visual acuity is still going down, or visual functions are deteriorating in spite of edema going down. So I think there it has very, very important role.
Okay. Thank you, ma'am. Anybody else from the panel would like to add anything to this discussion before we move on to the next speaker?
Yeah, just one point, Madhavi. See, in
Yes, ma'am.
MS, in neuroinflammatory disorders, as very nicely covered by Professor Dhar, we have come to a point where OCT has been included in the revised McDonald's criteria. Okay, so over a period of time, even in neurodegenerative, it's just a matter of time when OCT will be included. We're going there, and many times probably the neurologists are doing the OCT at their own level. They might not involve a neuro-ophthalmologist. They might be, I don't know, abroad. I think that's what's happening. OCT has become a very important tool in the armamentarium used by the neurologist. And the criteria are being revised on that basis. Probably the time will come when we have revised criteria for IIH, for Alzheimer's and Parkinson's, which will include OCT.
We have done a study in compressive lesions, intracranial space occupying lesions, and what we did OCT in these cases are NFL studies, but we found that if the RNFL layer thickness is less than 75 micron, then the patient is not likely to improve even after removing the space occupying lesions. Secondly, I also want to emphasize that what is the significant change in OCT? That means if there is a 2 micron, 3 micron change in OCT, that is never considered to be significant. The change in significant OCT is more than 6 micron. So if the change is more than 6 micron, then only we consider that there is a thinning or thickening. Thirdly, in cases of optic neuritis or any neuropathies, so the visual acuity is usually reverse than the OCT. That means in the initial stage when the edema is there, the OCT is thickened or normal and the vision is deteriorated. While subsequently after the 3 months, the OCT becomes thinned, but the vision improves because in optic neuritis, subsequently the vision improves, but there is always a thinning in the OCT. So these are some of the points I wanted to highlight. And one more thing about Parkinsonism and Alzheimer. What is said is that Parkinsonism, the central ganglion cells, they are affected, while in Alzheimer, it's the peripheral ganglion cells which are affected. Okay.
We have had a
Thank you so much.
wonderful discussion. Just I would like to add a couple of points here. Dr. has very beautifully covered most of it. As you were asking about the serial monitoring in IIH, so if the patient is there with IIH, I think if you have socioeconomic considerations, a good fundus examination coupled with visual field will be even more useful. That will tell the how the disease is going. And if we have a stable disease and there are no economic constraints over there, then possibly 6 to 8 weeks would give a significant change to be monitored. But again, correlate both RNFL as well as MDCL. In case of children, the question was that whether we'd use it. Yes, we use it, but we do not have the normative database which is in the machine. But there are published literature, so we can use it according with that. And then last point I would just like to add is uh, that there are additional ancillary techniques, especially using the EDI OCT, which can be very much helpful in distinguishing between doubtful cases of papilledema, pseudopapilledema, and even detecting intrusions. They can all be coupled even in a patient where the disc edema is almost resolved. Over there, you are doubtful that whether there is still fluid or not. These things could be additional things that can be tried. Thank you.
One more
Thank
thing,
you. Thank you, everyone.
one more point. We had done a study on optic neuritis, serial study on OCT. And in that project, what we had seen is that ganglion cell thickness that is significant after 1 month, while retinal nerve fiber layer thickness, thinning is shown after 3 months. So ganglion cell thickness is an early biomarker as compared to RNFL thickness. Thank you.
Thank you so much, everyone, for your inputs.
Just one last thing.
Thank you.
Yeah,
Yes, ma'am.
did Dr. Meenakshi cover the direct visualization of drusen? The consortium has shown that you can directly visualize the optic disc drusen as a hyporeflective core with a hyperreflective margin. I'm not too sure whether that image, that's a very important development, that you can directly visualize the drusen, which is calcified on the OCT. Thank you.
Thank you. Thank you so much, everyone. Special thank you to Professor Dhar. Thank you. That was an amazing presentation. With this, we would like to move on to our next presentation for today, which is by Dr. Rishikesh Mai, who will be talking on paralytic strabismus evaluation and basic management.
Am I audible now?
Yeah. Sir, could you share your screen, please?
Yeah,
Yeah,
just a
I would
sec.
like to introduce Dr. Rishikesh Mai, who's the director of Avadut Nethralaya at Nagpur. He's the consultant ophthalmologist there, working for over 15 years and a fellow of pediatric ophthalmology from Shankar Nethralaya, Chennai. He has a number of awards and papers to his credit and a number of publications as well. He is a reviewer of JCOR as well as the DJO journals and editor of the Indian Journal of Strabismus and Pediatric Ophthalmology. Welcome, sir. We are glad to have you with us today. And over to you for evaluation and management of paralytic strabismus.
Thank you, Dr. Madhvi. Thank you, AIS, Dr. Santosh, and all the team for including me in this important session on neuro-ophthalmology. Just a couple of points before I start. There are some products which I will be showing in this, but I don't have any financial interest in that because it is primarily for in a neuro-ophthalmology session. So I won't be covering any strabismus surgery in this. Cover the non-surgical management of the paralytic strabismus. Primarily, it is meant for the postgraduate. So before we start, I'll just brush up with the important ocular motility and the muscles which are involved in this. As everybody is aware of this, I won't be repeating it, except that inferior oblique is a elevator and a superior oblique is the depressor. And superior obliques applied by the fourth nerve. The lateral rectus by the sixth nerve, and rest all the extraocular muscles are supplied by the third nerve. So the evaluation, like all other cases in ophthalmology, includes these points of phakic strabismus. Also, I'll share only the important ones. In history, we need to include the age at onset, and if the patient has binocular diplopia, absence of binocular diplopia does not rule out paralytic strabismus. It can still be present, especially if it is a congenital one. Also, the mode of onset, whether it is gradual or sudden. And we need to ask about diurnal variation, because myasthenia, which we call it as a master mimicker, can be can present as any of the paralytic strabismus or combination of different nerve disease. But absence of diurnal variation does not rule out myasthenia as such. Coming to the history part, we also include the which eye deviates more often, the direction of the deviation, and whether there is any alteration in gazes or an amount of squint, whether it is a small angle squint or a large angle strabismus. Coming to the subjective ocular complaints, the patient might complain of double vision or blurred vision. Sometimes, along with the binocular diplopia, the patient can have headache or asthenopia, which can point towards raised intracranial tension, especially following IH, and also some patients will tend to close their eye in order to avoid binocular diplopia. We also need to ask for precipitating causes, whether the patient has any history of head or face injury, or any recent illness, especially viral illnesses, any ophthalmic or orbital or a brain surgery, and maternal history. On birth history, especially history of forceps delivery, because forceps delivery has been found to be associated more commonly with a bilateral fourth nerve palsy. Coming to general examination, before we start examining the patient or perform the motor and sensory test, 2-3 points which we need to look into the patient's patients is that whether the patient has any facial asymmetry or any cause of pseudo strabismus like epicantral fold or hypertelorism. Also look for any lid abnormality, any lid scar or any ptosis or in lid retraction if that is present. Abnormal head posture. This is something which we need to consider before we go ahead with the examination part. And if any abnormal head posture like a chin up posture or head tilt in this child was quite severe, but it can be quite subtle at times, or any abnormal any face turn. And if abnormal head posture is present, we need to correct that before we will go ahead with further evaluation. Visual acuity has to be measured. I won't go into the details about this. Then we go to the motor evaluation, mostly the cover test. So before we look for ocular movement motility, we should look for the cover test. Basics about cover test is that we should ensure that the patient's vision is better than 6/60, so that he can focus at the distance target as well as for near target. Also ensure that the patient is able to take up fixation when the one eye is covered, because sometimes, like in this case, I'll be just sharing the video. Like in this case, the patient, you can see, is a case of a left-sided third nerve palsy, and it was severe limitation of movement. Even the left eye is not able to take up, is not able to cross the midline even on attempted adduction, and on he is not able to take up fixation. In such cases, doing a cover test will not give us appropriate reading. So it is not necessary that the deviating eye will be the affected eye. Sometimes it will be the patient might, depending upon the visual acuity, the patient will take up fixation with the eye with better vision. Like in this patient, initially we thought it is a left-sided exotropia, so left-sided nerve palsy or squint, but he had better vision in the right eye actually, and the ocular movement clearly shows that he has a ptosis as well as there is limitation of adduction in the right eye. So it is not that the left eye is affected, but it is the right eye. So under binocular circumstances, he was taking up fixation with his right eye. So that gives us a secondary deviation. So when we are evaluating a patient with paralytic strabismus, we should look for primary and secondary deviation. Primary deviation is when the normal eye is taking a fixation, whereas secondary deviation is when the paretic eye is taking a fixation. When the same patient, when we are evaluating with alternate prism cover test, this was an exotropia, so we'll do a base in prism, and we will now he is taking up fixation with the left eye because the prism is in front of the right eye. Gradually, we increase the power of the prism to get a neutralization point, which I got now. And then I'm measuring with prism in the other eye, I mean the right eye taking up fixation. So here I will have to use a higher grade of prism. That means that the deviation which I'm getting with the right eye fixating is the secondary deviation. Uh, uh, she is a 14-year-old female with road traffic accident almost 2 years back, and she had a complaints of vertical binocular diplopia. As you can see, she has a slight head tilt. Head tilt might not be very severe in many of the cases of fourth nerve pulsing, but a careful ocular movement will show that under binocular circumstances, there is not much of squint in the primary gaze, but you can see that she has got an inferior oblique overaction in the right eye and superior oblique underaction. So that points towards a fourth nerve palsy in the right eye. Any patient with binocular the vertical strabismus, or a vertical diplopia, we should do something called a Parkes three-step test. Actually, we need to do the cover test in all positions of gaze. That is one more that will give us a proper evaluation. This patient doesn't have a squint. It is only a video to show how to do a cover test in different positions of gaze. Uh, 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 I'm doing it in up gaze now and in down gaze. So we don't need to shift the fixation target. We need to adjust the patient's head and do the evaluation under different positions of gaze. Now it is for the right head tilt, and then we'll go to the left head tilt. This is mostly done for distance. For Parkes three-step test, we do it in primary gaze, the side gazes, the chin up and chin down position, and then the head tilts. A patient with right-sided fourth nerve palsy, and as in this case, you can see that he has a hypertropia which increases on right face turn and right head tilt. So usually a patient with a fourth nerve palsy tends to adopt a head tilt on the opposite side. Sometimes a simple head tilt can also give you a lot of clue about the deviation about the eye which is being affected. This is a patient with vertical diplopia and following a road traffic accident again. And you can see there is a slight inferior oblique overaction. Actually, acquired superior oblique palsies usually have inferior oblique overaction more often than having a superior oblique underaction. Clinically, inferior oblique overaction is far more detectable, but you can see that on attempted head tilt, he has got the hypertropia in the right eye is increasing, whereas it disappears completely on the left head tilt. So this is a case of a right-sided fourth nerve palsy. Coming to the sixth nerve paresis, ocular movement, she is a patient. This is one of the most commonest presentation of a sixth nerve palsy in elderly age group, a diabetic patient with a left face turn. And you can see that she has got a abduction limitation in the left eye, which points out towards a left-sided sixth nerve palsy. You can sometimes the sixth nerve palsy is quite subtle, and in this case, the primary and secondary deviation might help you to find out which eye might be parietic. In this case, he has got a mild left face turn, and on Spielman occluder, when I occlude the right eye, you can see that the esotropia is much more with the left eye taking up fixation. So this is the secondary deviation I'm getting. The same when I cover the other eye, the deviation is not much. This ideally you should not use a torch, but while checking for ocular movement, now you can see that there is abduction limitation in the left eye. So the next part which we need to evaluate is the pupils, because pupillary examination forms an important part while evaluating a patient of paralytic strabismus. Sometimes it might be anisocoria, which is more in dark, like in case of Horner syndrome, or it can be more in light. Actually, it's quite difficult to photograph anisocorias in Indian eyes because of the dark pupil. There is no rule that nerve palsy can be unilateral. Sometimes it can be bilateral also, especially congenital ones. Congenital fourth nerve palsy, bilateral, is comparatively more common. Like in this kid, you can notice that on primary gaze there is not much of squint, but on dextro version the left eye is going up, and on levo version the right eye is going up. There is inferior oblique overaction in both eyes, superior oblique underaction, and a V pattern. So it is a case of a bilateral fourth nerve palsy. Usually in forceps delivery, there can be damage at the inferior colliculus level, where the decussation of the fourth nerve happens. So a bilateral fourth nerve palsy is more commonly congenital compared to acquired one. There are two other tests which we can do to find out the amount of torsion which the patient has. That can also give a clue. Usually the distance between the center of the macula and the disc it creates angle with the horizontal plane, which increases on fourth nerve palsy. So a fundal torsion can be easily seen if looked properly. The other subjective test for measuring this torsion is double Maddox rod test. When you place the double Maddox rod in both the eyes and try to get parallel lines, you will see that by the amount of rotation which we have to do in the trial set will give you the clue as to the amount of torsion. Usually, if it's a bilateral fourth nerve palsy, this torsional component is more than 10 degrees. So, but it needs a lot of cooperation and understanding from the patient side. Certain ancillary tests which can be added for further assessment of paralytic strabismus are diplopia chart, Hess chart, imaging, and force reduction and generation tests. Word about diplopia charting, it can be done in your clinic. It doesn't need any instrumentation much. So your patient sits 1 meter away from a screen or even a wall, and you place a red-green glasses alternately, first in the right eye and then in front of the left eye. And you see the amount of separation which the patient has to appreciate. Again, it needs a lot of cooperation from the patient side, but the gaze where the separation is more is the affected side usually. Hess chart is another device which not only helps in diagnosing but also for a follow-up and also to look for spread of committance, which can happen over time in a case of paralytic strabismus. In this case, we place this hair screen, usually black colored screen with red lights in it. The patient sits 1 feet away with red and green glasses. The green glass, the eye with the green glass is usually the testing eye. And we, depending upon the patient's responses, we chart the patient response on this chart. And then, especially for the postgraduates, if this comes as a spotter, the eye with the smaller field is usually the affected side. As in this case, there is only lateral rectus and inferior superior oblique movement are present. This is a case of a third nerve palsy. Similarly, in this case, you can see that the smaller field is the one in the left side, and it has a superior oblique underaction. So probably this is a superior oblique palsy. The spread of committance can happen along with this, and you will have a overaction of the ipsilateral agonist. Then it will go, the committance will go towards the other eye also, and depending upon that, you can say how much is the duration of this squint being present there. Sixth nerve palsy, you can see that the affected side is on the right. So there is an absence of the lateral rectus movement. So definitely this is a lateral rectus palsy. So further test which we need to do is the neuroimaging. Like in this patient who had third nerve palsy actually on the left side with the ptosis, and he also had an anisocoria, and he gave history of complaints of severe headache as well. So this patient had a sphenoidal sinus tumor compressing upon the third nerve on the left side. So ideally, I usually image all the cases of third nerve palsy, but this might be an exam question that when to image a case of third nerve palsy, usually divided into medical and surgical causes, medical and surgical types rather. The medical type does not involve the pupil. Usually, it is a complete nerve palsy, usually associated with some ischemic causes like hypertension or diabetes, and aberrant regeneration is absent in these cases. When there is pupillary involvement, when there is incomplete palsy, when there is one or more cranial nerves involved, or there is aberrant regeneration, it is better to image because it can be associated with some intracranial pathology also. So we usually we definitely image third nerve palsy in case when the patient has a non-recovering pupil sparing palsy for more than 3 months, or a pupil involvement along with all the other points. Sometimes the aberrant regeneration might be very subtle, as in this case, this patient didn't have any history of trauma or anything, but you can see that on attempted adduction in the left eye, there is retraction of the lid. This is, we call it as the inverse Duane syndrome, which we usually present is a long-standing third nerve palsy. This patient actually had a PCA aneurysm, or posterior communicating artery aneurysm, compressing upon the third nerve, which is a very common cause of a surgical third nerve palsy. Another case, sometimes in the aberrant regeneration is quite obvious, as in this case, there is lead retraction in the right eye on attempted adduction, and also on attempted down gaze. He has got lead retraction as well. Sometimes in case of a sixth nerve palsy, which is quite obvious in this case, she has a limited abduction in the right eye. But don't stop at this. Do a proper fundus examination, because you might have something like this, papilledema. But again, don't stop at this and just consider it as a IIH. Always do an imaging and all the workup which is required for IIH, like the opening pressure and from a neurologist, because sometimes the imaging can show CP angle tumor or any intracranial abnormality as well. So coming to the next test, which is, we call it as a force duction test. Actually, when we describe the ocular motility, we usually use the term limitation and instead of restriction, because restriction is something which we feel on a force duction test. So this is more of a feeling. If you feel that the muscle is tight, we label it as a positive force duction test. And if we feel it is loose, there is no much of a resistance or tone of the muscle, we label it as negative force duction test. The binocular single field is something which helps us to look for which part of the binocular field there is no double vision or diplopia, which can be charted. I don't have an access to this actually, but it can help in good rehabilitation of a patient, especially who complains of binocular diplopia. Coming to the management part now, the management of paralytic strabismus main aim is to provide diplopia free field, especially in primary and down gaze. That is the most working gazes of the patient. So I mean, the diplopia and the squint is different in different positions of gaze. So it is very difficult to correct in all positions. So the primary aim is to correct in primary and down gaze, and also to correct the abnormal head posture along with that. So treatment modalities can be non-surgical and surgical. I'm not going into the surgical part because of paucity of time. The non-surgical modalities are these. Actually, the glasses provide as a means for any additional treatment like prism therapy, and they can help in ocular myopathies and myasthenia as well, the crutch glasses. Initially, I mean, you can simply ask the patient to occlude one eye, because that will help in relieving the binocular diplopia, though it is not the main treatment. Orthoptic exercises is more for patient satisfaction. They actually don't help much for improvement in paralytic strabismus. More definitive treatment in order to correct the binocular diplopia is prisms. So prisms can be given if there is a stable diplopia. There is no torsional component to that, and if sometimes after a surgery, if there is some amount of residual diplopia also, you can give prisms to the patient. Prisms, the advantage is that they provide a binocular vision to the patient, so it is not kind of occlusion. But the disadvantage is that you cannot use them for variable squint and also for cyclotropias. There are two ways we can give prisms, either incorporated into the glasses itself, or stick-on prism, which we call it as Fresnel prisms. Prism glasses that is incorporated into the glasses itself can be given for smaller angles. I don't give more than 12 prism diopters. They can be divided into two eyes. So if the patient needs 12 prism diopters, you can divide it into 6 and 6. The disadvantage is that they are thicker. So cosmetically may not be acceptable for many patients. And obviously for large angle squints, we cannot give them. So for these kind of cases, we can give something called Fresnel prisms, which are the advantages that they can be given for large angle squints, especially they can be given if patient I mean surgery is contraindicated for these cases for whatever reasons. But the disadvantage is that the availability is not easy, they are expensive. And one more thing which I have noticed over time is that the crevices in between those Fresnel prism, the dust gets accumulated, and they need to be changed frequently, because otherwise the patient will not use that eye. He will feel that there is no binocular diplopia, but actually he is not using the eye in which the prism, the Fresnel prism is being placed. So first we need to do a trial with the trial set of the Fresnel prism, And these are the fingerprints. And actually, they are stickers which are placed on the inner side of the glasses, depending upon which eye or which side the diplopia is present. Like if the patient has a superior oblique palsy in down gaze and diplopia only in down gaze, then you can place them only in down gaze also. So coming to the next part is chemodenervation. Chemodenervation, we primarily use botulinum toxin A, which helps in temporary paralysis of the ipsilateral antagonist, thereby producing a flaccid. I mean, it helps in blocking the release of acetylcholine at the neuromuscular junction, thereby producing flaccid paralysis. So in the case of a sixth nerve palsy, which most commonly we use it, we tend to inject it in the ipsilateral medial rectus, so as to paralyze it. So usually they are given for long-standing splints or even in ischemic causes also. The advantage is they not only help in correcting or reducing the binocular diplopia, but they also prevent the contracture of the ipsilateral antagonist. They are available in different forms. Usually what we need is a very small dosage of around 2.5 to 5 units. So I mean, for individual cases, we can't order we cannot order the entire vial of botulinum toxin. It's better to liaise with a neurologist who use it quite often. The disadvantage is that they are temporary. The effect is temporary. It lasts for 2 to 3 months, and also the cost for some patients. There are two ways we can give it. The third is using EMG. I don't have an access for that. Either you can directly, using a superior rectus forceps in your cataract set, we can directly inject hold the medial rectus. This is for a case of a lateral rectus palsy, and inject it into the belly of the muscle. It is important that you inject it into the belly of the muscle. This is slightly a blind procedure. More defined or more under visualization is open. You don't need to open this much actually. You just need to open a bit. Inject it into the belly of the muscle, and after that apply a cotton tipped applicator so as to avoid any spilling of the drug, and wash it thoroughly, because spillage can lead to ptosis. I haven't experienced that, but it's a known complication. This is one of the patient who needed multiple treatments. He had iron gate fell on his head, unfortunately, and he developed sixth nerve palsy in the right eye and a facial nerve palsy or seventh nerve palsy on the left side. Initially, we tried with botulinum toxin in the medial rectus of this eye, but still he had a residual squint. So finally, we had to operate him a medial rectus recession, was able to give the complete correction. There are various, as far as the fourth nerve palsy is concerned, there are different types which have been divided up depending upon the surgery which we need. I won't go into the detail about this, but most of the cases will need if there is inferior oblique overaction, we'll need an inferior oblique correction. The case which I had shown previously, who had a right-sided fourth nerve palsy on head tilt, very much obvious. I did a inferior oblique recession and a superior rectus recession, and I was able to get a good correction with this. So with this, I would like to conclude by saying that history and general examination are very important in case of paralytic strabismus. Assessment should be tailored according to the individual case, but there are certain general rules which we need to apply for all these cases of paralytic strabismus. And not only the diagnosis, but ancillary tests will help as far as possible in further planning or deciding the management part. But counseling becomes an important part whenever you are treating a case of a paralytic strabismus. Thank you.
Thank you very much, sir, for that illustrative talk. It's a really, really vast topic which you've managed to summarize and tell us in a very short period of time. I would especially like to appreciate your video about the cover test, which is a very basic test most postgraduates need to know, especially because you showed it in a normal patient so that they could understand the head tilting and the up and down gaze that can be evaluated. And also the important discussion about when to image a third nerve palsy, which is also a very essential and a sort of a big topic of discussion in paralytic strabismus. A couple of questions I had, one of which were when you mentioned about binocular diplopia and paralytic strabismus. Could you or any of our panelists just elaborate a little bit about that? How a binocular diplopia that you said a lot of time may not be a paralytic strabismus also.
No,
So I think what is, Dr. Virender, you want to?
No, what I wanted to say is not all the paralytic strabismus will have
Yeah,
binocular.
yes, sir. Yeah.
Usually the congenital ones don't complain of binocular diplopia. That is what. Yes, sir.
Sometimes congenital squints which decompensate later in life. Sometimes people are born with superior oblique palsies. They manage all their life with a head tilt, and later in life it decompensates. Or similarly, I think exo and meso tropias, sporias going into tropias. Probably those are like non-paralytic, and they can present non-paralytic and non-neurological, and they can present with diplopia. I'm sure Dr. Digvijay will have lots to add to that.
Yes, no, I was actually coming to that only, that I think that it's both ways, that not all paralytic squints may show binocular diplopia, and not all binocular diplopias maybe would be paralytic squints. They would be, so even comitant squints can have, particularly when they've just been decompensated, and this is particularly there. And at the same time, just the presence of diplopia could also be because of a lot of other reasons. I mean, restrictive squints, of course, but comitant and incomitant both can cause it. And break of fusion that happens very often, in IXT, they can present with diplopia. I think all of us have gone through that one sort of form of diplopia that does happen when we are, very tired. So, I mean, that's the thing. It's both ways.
And another thing I would like to ask about all your experiences about Botox with paralytic strabismus. How accepting are patients to that? And is it like one of the higher options you would give for management, or maybe later on after trying like patching and conservative measures? Like how aggressive would we be for Botox in paralytic strabismus?
I think there are specific situations. I feel that when I have used Botox, when there are multiple muscles involved, then it's obviously difficult when you're looking at things like
Right.
the oculomotor nerve, even for the torsional form of strabismus. But it works well for, let's say, the abducens palsy to some extent. Generally, you have to discuss with the patient as an individual discussion. You have to have an individual discussion with the patient as to what they're expecting in their outcome. But I remember there was one case I had recently where there was somebody who's from a media background and has to be publicly facing, and that's it, and couldn't really manage their day-to-day work without that, and they were wanting it, that please do it. So we discussed the expectations, and we did it, and they were quite happy with it. And ultimately, I think that it recovered on its own, the paralytic strabismus for them, and things worked out well. Of course, there was a period in between where the Botox was kind of wearing off, and they hadn't yet fully recovered, but they were able to manage that short period there. But it's again a case-to-case basis, and the outcome and the expectation has to be set.
So it's a very individual based approach about
Yeah.
how fast they want the recovery or like the outcomes that way.
Yeah, but one most important thing when it comes to Botox injection is that you need to rule out antagonist contracture. So in chronic cases where antagonist has already gone into contracture, your Botox is not going to work. So only in acute phases where you have no contracture, you can give Botox. And as Digvijay has said, that will definitely works very well in sixth nerve palsies, but has probably very poor role in third nerve or fourth nerve palsies because of multiple issues. Multiple muscles are involved, and then you need to balance which muscle and what muscle. So the only working muscle is LR. If you paralyze that also, then it becomes very difficult for patient. So those are the two things. So it's important to rule out contracture. And so it may work only in acute cases, may not be so useful in chronic cases. And it's also important to counsel the patient that the effect is temporary. In microvascular occlusions, yes, it is definitely going to resolve by that time. But in other kind of traumatic or in other kind of things, it may not resolve. The paralysis may not resolve. So in that case, you may have to repeat the injections or may have to end up doing surgery.
I
Right,
agree with
right.
what Dr. Digvijay and Dr. Swati have been saying. We have to individualize. Obviously, a patient who has a microvascular ischemic is likely to resolve in 6 weeks to maybe 12 weeks. So if the patient is fine enough and if he can give monocular occlusion with magnetar filters or even otherwise occlusion, patient is able to manage, otherwise is comfortable, it can be avoided. But then the requirement, as Dr. Digvijay was giving example of a person who needs to have binocular vision, would be important. One more indication where it might be important is traumatic palsy, where it has less chances of spontaneous recovery. So you can consider more in those. I'd like to give more often in children because the binocularity and amblyopia would be the other concerns. They are more likely to develop dense amblyopia, though it requires GA, but I like to give there for this reason. I have a different experience with third nerve palsy. I have given in patients with third nerve palsy with large exotropia to the lateral rectus and at times to inferior rectus. So it has helped them greater recovery, though not published, our experience. So the patients do have a greater horizontal range of movement as well as the vertical range of movement. And we have been able to do a lesser surgery rather than a more difficult procedures like superior rectus, lateral rectus transposition, sorry. That so a more research kind of procedure has been feasible for them. This has been our experience about this. I would like to add a small thing about for the benefit of the postgraduates is that always in a patient with a paralytic squint, we should consider the principle of localization. So that would help very much. In a unilateral palsy, according to the accompanying features, we can localize that it is likely to be at which level. Is it at orbit? Is it in the isolated palsies will usually in the subarachnoid space. So, and brainstem lesion would have usually associated other cranial nerve palsies. Again, in orbit and in cavernous sinus, we are likely to see multiple cranial nerve palsies. When we see bilateral, some of the important considerations would always be like, think of myasthenia, think of cavernous sinus, think of brainstem lesions, and something like a Guillain-Barré syndrome. So these four would be very important differentials for the bilateral. But otherwise, principles of localization would help you guide what kind of imaging is needed. If we are prepared for it, we'll be able to have a greater discussion with the neuroradiologist, and we can get maximum for our patients.
Right. Yeah. Thank you. Thank you, sir, for that input.
I want to ask something to Dr. Virendra. So, Dr. Virendra, you have used it in all kind of third nerve palsies, even in traumatic also for that matter. And
Yeah.
whether it's complete or partial or just the MR involvement where you have used Botox.
Now, all are traumatic. Majority of the patients with this indication have been traumatic, and it's multiple muscles involved, not medial rectus alone. The superior rectus and inferior rectus have been usually been balanced. So both are affected, -3, -4 in both. At times, -3 in inferior rectus. So gave, based on FTT, gave in inferior rectus.
So you gave same kind of dose to IR and LR both because then, or you
Yeah,
titrate the dose, I think, accordingly.
maybe like at least 5 minutes for lateral rectus and 2.5 to 5 minutes for IR, depending on the difference in the superior rectus and inferior rectus.
Okay, thank
But I
you.
think from a PG standpoint, of course, the standard dose, and you need to just know about the standard format. These are, of course, individualized cases. From a PG perspective, for which this is planned, I think that's what they need to know.
Yeah.
Definitely. Thank you. Thank you so much for that discussion. Thank you again to Dr. Rishikesh Mai for his wonderful presentation. And with that, we'll move on to our next speaker for today, Dr. Sucheta Parija. Ma'am, could you please share your presentation?
Yeah, hello.
Ma'am is the professor and head at All India Institute of Medical Sciences at Bhubaneswar. She has studied from Cuttack and Burla, and her research interests include cataract, pediatric ophthalmology, strabismus, and glaucoma. She has done a number of long-term as well as short-term fellowships at Arvind Eye Hospital, Shankara Netralaya, LV Prasad, as well as Arvind in Coimbatore. She has a number of honors and awards to her credit and a number of publications as well. Ma'am will be speaking about approach to disc edema, a case-based approach. Ma'am, over to you.
So, a very good afternoon to all of you. Can you hear me?
Yes, ma'am, loud and clear.
So, I should thank Dr. Santosh Sanovar and the AIS team for giving me this opportunity. So, I have no financial interest in this presentation. So, when we are dealing with the optic disc swelling, what happens actually, it's a manifestation of a range of broad things which is affecting the optic nerve or the anterior segment of the nerve. So what happens when you either the optic disc swells up or due to the trauma, it can become pale. So you can have a lot of, when we look at the optic disc, you can have a lot of manifestations, and then you say that whether actually we are dealing with a swollen disc or we are dealing with something else. So let us understand the basics sometimes, and we should not be confused. So what do we mean by optic disc edema? Actually, by meaning optic disc edema, it is a true swelling, and the axons are actually swollen in these cases. So what do I mean by papilledema? A very important thing, because a lot of cases are referred to us, or even the postgraduate, they always tell any disc edema they see, they write it as papilledema. What I want to emphasize is that it is papilledema is usually bilateral, but you can have a asymmetric papilledema which can present as unilateral. But the most important thing is papilledema is told when you have a disc edema due to rise in the intracranial pressure. So it is the concern here will be of the optic disc due to rise in the intracranial pressure, and also we are dealing with a disc edema. What do I mean by a pseudo-papilledema? Well, there is a swelling of the disc which is not associated with the actual axonal swelling. And then what is optic atrophy? It is afterwards what happens, the axonals die down and then you get a pale disc. So when we have, or when we look at the fundus and you have this type of disc looking at you, then the question comes, is this a true disc edema or we are dealing with something else? So if you look at the first picture, what I want to emphasize is, are we dealing with a normal disc or we are dealing with an abnormal disc? So we always have an undergraduate teaching of saying how is the disc color, margin, what are the blood vessels, what are the any exudates or any hemorrhages, and what is the macula, whether it is also having any associated edema, hemorrhage, etc. Coming to the second picture, when you are seeing, here you can very well see that the optic disc is swollen, it is elevated, the margins are blurred, there is obscuration of the blood vessels, and then there is a tortuosity of the vessels which is there. Well, there are not much of a hemorrhage in these cases. Coming to the last picture, the third picture which I am showing you, here what do we see? We see a optic disc swelling, but there is some bumpy things which is there in it, and you can very well see the optic vessels which are coming out from it. So looking at this, can we basically say that either we are dealing with a true or a pseudo disc edema? So what are the pictures? You should be having a mechanical signs and vascular signs. Very important is there has to be elevation of the disc, there has to be loss of the cup, margins has to be blurring is there. Sometimes you can have some folds, and then there can be nerve fiber layer edema. Hyperemia of the disc is always there. There will be venous dilatation and peripapillary hemorrhage and exudates. So how do we then approach these cases? If you are dealing with a bilateral optic disc edema or a unilateral optic disc edema, first and foremost important thing is your history. So in history, we always look for the visual disturbances, because if your vision is not affected and you are dealing with a disc edema, or your vision is affected, or actually you are dealing with the optic neuropathy in those cases. Symptoms of raised intracranial pressure, other systemic symptoms are there or not, or the patient is having any other medical history, or he is under some medications which actually will be causing the disc edema. Coming to assessment, very important is the visual acuity, and what I give emphasis is color vision has to be taken in most of the cases. Check for the pupils, mainly you have to write in the neuro-ophthalmic whether there is a RPD present or not, and then you go about to do a visual field testing. Look for the slit lamp examination for any other ocular inflammation in the anterior segment or in the posterior segment, because you can be having a disc edema with the uveitis and not as such a neuro-ophthalmic case. Fundus examination, and then you take care of all the visual ancillary tests which you need. So in history, what is important is we tell which signs are very, very important that you should know that this is a papilledema, not a pseudopapilledema. Headache is something which is there, but headache, when they say throbbing headache, more when they wake up in the morning. The transient obscuration of the vision and it's like few seconds. There is a postural thing, and there is a browning effect that is more towards the papilledema you are dealing with, and there is a tinnitus. You ask in 60% of the cases, they will have something losing in their ear, and then they can, from the distance when they are looking, they see double vision. But very important, are you dealing with some refractive error, or there is a family history of such disc which you are looking at? So when you are looking at this now, this is you can very well say there is a elevation of the disc, and then there is a obscuration. There is the cup is obliterated, and you can see the splinter hemorrhages around it, peripapillary hemorrhages. Well, this is established papilledema you are dealing with. But sometimes when you see a optic disc which looks more like a pale than looking like a hyperemic, and then still you can see some folds around it. This is what I was talking to you, and this is the patterns line which we are talking, which we may not even pick up in of the fundoscopy when we do it. So very important thing when you do a slit lamp examination, do a 90D examination and see thoroughly the optic disc. Take some time to look at everywhere around the optic disc. Sometimes you can have a disc edema, but something else is there along with it. Look at the macular region. Also, there is something which is forming like a exudate, like a star. So are you dealing with something else? Is it something inflammatory or infiltrative than just a papilledema we are talking about? So in this cases, so whether it's a unilateral disc edema, the most common causes when you see that your ocular examination is normal, your visual acuity is normal. So that is either you are dealing with a pseudo-optic disc, or you are dealing with the asymmetric papilledema, or it is a incipient NEI1 you are dealing with. Now, if there is an abnormality anywhere and you see that even the vision is coming down grossly, that is, you are actually dealing with a papillitis in those cases. You can have a history of diabetic in some of the cases. You can be dealing with a diabetic papillitis. Looking at the macular star, actually you are doing with a neuroretinitis. So what are the common causes of unilateral disc edema? We always ask, and then papillitis comes as the first, or you can have anterior ischemic neuropathy, neuroretinitis, ischemic CRVO, or a infiltrative leukemia in those cases. So that has to also kept in mind. So now looking at this picture, what exactly are we seeing? We see something pale and something which is sitting. So if you are careful enough, this is, and look at this second picture, you see something like a bumpy thing which is occurring over here. And third picture, when you see, what do you see actually in this? You see there is something going out. You can see the blood vessels over here, but what do you see? Here you cannot see something which is there. And look at the optic disc size. Is it normal or not? So basic teaching when we had, or is there a double sign you look at? So what actually you are dealing with? You are dealing with a myelinated nerve fiber or optic disc drusen or a hypoplastic disc. So if you have so much of a doubt, very important for us to do is, instead of asking for neuroimaging, first and foremost, you can go and do. If you have autofluorescent, go ahead and do a autofluorescent. You can very well find out the calcific areas which are hyperreflective, which is nothing but the optic disc drusens. So why am I emphasizing? It's like, what are you going to do? We have in the morning session is a discussion. Optic disc drusen is a calcification which is there in front of the lamina fibrosa. So very important in those cases, you can do a non-invasive procedure. If you don't have anything, you have a B scan. Go about from the B scan and see when you are looking at a hyperreflective area in the optic disc, that is nothing but has to be optic disc drusen. And even if you take the gain down also, everything goes off and only that reflective area is there. You can do the 30-degree tilt sign and you can see. But if it can sometimes be associated with edema, can it be a papilledema? Look for that crescent sign which we were talking about. So B scan is there to help you out if everyone has it. And then if you have a enhanced depth OCT we were talking about, that very clearly you can get the optic disc drusen which is buried inside, and that is what we get, a round hyporeflective pore with a hyperreflective margin, and then you can get a perilamellar hyperreflective area. So these are typical signs where you are actually dealing with the optic disc drusen. if there is no drusen, rule out papilledema, you have to go for a MRI. We usually ask for MRV veno when we have to think that we are dealing with something to do with the venous thrombosis, and you are suspecting that and you are asking for it. And then if there is a signs of ICT, papilledema is the common thing, or the other causes as we have discussed. Coming to the bilateral optic disc edema, true disc edema, yes, you do ask for a MRI, MRV, structural changes, papilledema, raised ICT, and then you have to ask for a LP in those cases. And then if you see that there is a rise in ICP, typical IH, then if you see atypical, then you have to go for blood investigations in most of the cases to rule out any infectious or inflammatory causes. Very important also, if the patient is giving a history of taking certain drugs, you have to be careful enough, and you can have a raised ICT in those cases also. And also sometimes you do just a hemoglobin and you can see that patients who are also anemic or microcystic anemia can have a rise in the ICT with the disc edema. They will be presenting to you. Otherwise, it's a normal, if you have intracranial pressure, well, hypertensive retinopathy or other causes should be ruled out. Let's come to certain cases and we'll discuss it. This is a 22-year-old female with complaints of headache, intermittent blurring for 3 months. She has no other associated complaints, no systemic illness, but what she was giving that she was gaining rapidly weight and she was 80 kg when she presented to us. On examination, her visual acuity was 6/9. There was no RAPD, but this is how the optic disc appeared to us. So it's a bilateral disc edema. We are dealing with the true disc edema. So what we were suspecting that we are keeping in mind of something of IH more feature, and then we asked for straight off asked for a neuroimaging. But we went ahead to do the fields, which gave us a clue because there was enlargement of the blind spots, and then we did a brain imaging, which came out to be normal in these cases, and we went ahead to do a lumbar puncture, which came out to be high ICP in this case. Well, we are dealing nothing but with a high IH in this case. So second, this is another female who presented to us with headache and diminution of vision. But if you look at the left eye had a very, very fulminant disc edema, and the right eye was edematous, but not as so much. And she was losing vision of 6/60 in the left eye and 6/12 in the right eye. Immediately, we had a consultation with the neurologist with us, and then we went ahead we probed into the history, and she was giving some menstrual irregularities. So we asked imaging of the abdomen as well as the brain MRI and MRV. And if you can see, she has this enlarged ovaries, and which was suggestive of polycystic ovary. And if you go to the MRI, T1 contrast, you can see there is a narrowing of the right transverse sinus with no stenosis, suggestive of hypoplastic transverse sinus in this case. Well, she was, LP was done in this case, came to be high, and then we had to immediately manage her. We went ahead. So if you look at this IH treatment trial of modified Dandy criteria, she was fulfilling most of the criteria. And so treatment was basically to lower the pressure, which is very crucial. We started her on tablet acetacholamide and then asked her for a weight loss. So this is important thing, how in the first case it was weight loss, which was important, but we were doing a series of OCT in this cases, and she is really following up because we were thinking whether we will go for an optic nerve sheath penetration because her vision was 6/60, but she showed some improvement, so we did not have to go for this procedure. Well, if you have an intractable headache, more shunt surgeries will be helpful, and so these are some of the options. But if you have a good vision and IH, the patient can lose weight, and if they don't have sulfur allergic, acetacholamide will work in those cases. This is the case who came to for a routine checkup. So the man, the 28-year male, had come just for a visual acuity, having a 6/6 vision. He just wanted his routine examination, and this is what we found. So this is something lumpy bumpy, and please don't go. This is an artifact which you had because we had taken with a 20D directly for the indirect. And so some bumpy signs were there. We went ahead to do a B scan in these cases, and you can see the hyperreflect areas, which is looking like a drusen. We did a enhanced OCT, and this is what the OCT picture was. Well, for the patients with swollen optic disc and normal vision, it is the optic disc drusen, which can be the most common diagnosis. So a 12-year, next case is a 12-year-old female who presented with the inward deviation for 15 days. So there was a sudden onset esotropia associated with headache and vomiting. So on examination, she had a right eye isodeviation. We did there was a restricted abduction of the right eye. Visual acuity was 612 and 69. Pupils were normal and reacting, and cover test showed 30-degree ET in for near and distance. And fundoscopy is this what we for bilateral disc edema in these cases. We asked immediately for a neuroimaging because looking at the sudden onset, and she's having severe vomiting and headache. So had a consultation and asked for a MRI and with gadolinium. So what do we see in this T2 and T1 is, if you look at the thing, what was happening in this picture, you can see that axial T1 post-contrast image shows a patchy heterogeneous enhancement, which we are showing. So this was what was picked up. So it was in the pons, most probably as they gave pontine glioma they were talking about. Went ahead do it with the neurosurgeon's consultation. They asked for a MR spectrography, and then you can see there was an increase in the pollen peak, and well, it was sent to the neurosurgeon, and they went ahead to do the surgery in this case. Coming to another case, this patient presented, 42-year-old female, presented with complaints of intermittent blurring of vision. She was a known hypertensive for 2 years, but not on, she was very irregular on her medication, and this is what we found. The disc was hyperemic, there was sphincter hemorrhages, and you look at the blood vessels, AV crossing changes were there. So we just asked, very important in the OPD, you always ask if you see this type of a bilateral disc edema. We just asked her that record her blood pressure, and we saw that it was 20 by 110. Immediately the physicians were consulted, and she was actually a case of hypertensive retinopathy. So why I'm important saying that when you have a malignant hypertension, very well you can pick it up, because there will be some exudates, there will be angry looking disc, but even in such subtle cases, you can record a high hypertensive retinopathy, and that has to be immediately taken care of. This was another case of a 38-year-old male presented with diminution of vision. He's giving that I am immediately saying that he's saying 6 days history of right eye, there was deterioration. He's a known smoker. There was a type 2 diabetes detected 2 years back, and the right eye shows 6 by 60 and the left eye 6.6. And if you look at the disc, this looks more like a pale disc, and there is a disc edema. We went ahead to do the fields, and you can see a altitudinal field defect. We asked all the risk factor. We asked for all the blood investigations. We had a dyslipidemia, and but serum homocystinuria was normal. So this patient was again referred to the physician to find out any other coagulopathies, because we were dealing with a NAIO in this case. So this is another patient of 29-year-old male who presented with sudden painful loss of vision in the right eye. So if you look at the visual acuity, was 5 by 60 in the right eye and 6 by 6. The color vision was impaired in the right eye, and you can see a RAPD in the right eye, and there was some vitreous cells. Not it was a vitreous haze, and this is how the he was carrying actually a FFA done photograph with him. So this is how the disc was looking, and this is how the hyperemia of the disc is there. So we asked for a neuroimaging in these cases, and this is what you can see is this patient had, actually I don't have the other picture with me. So there was a left optic nerve sorry. I think there is something here. So I think I've taken the wrong thing. So leave it. This is not actually his picture, but what it showed was there was a optic nerve showing hyper signal intensity, and then this was a case of optic neuritis. And then as per the ONTT criteria, we have to start in for IV methylprednisolone, 1 mg for 3 days, followed by oral prednisolone for 11 days, and then taper it off. What is important is the MRI brain did not show any lesions in that cases, and were we dealing with a MS or a idiopathic optic neuropathy was further consulted with the neurologist. So coming to the last case, so this was a 22-year-old male who was a known case of a myeloid leukemia. Complaint came to us with a sudden painless diminution of vision for 10 days. Right eye was finger counting and to 1 meter, and left eye was 660. Anterior segment was normal, and when you look there was a RAPD, but when you look at the fundus, this is what the fundus picture was. There was a disc edema, but you have a subarachnoid hemorrhage totally sitting in both the eyes, and that is what was the cause for the loss of vision. He was already under chemotherapy, and the patient was consulted with the oncologist, and further treatment we were observing him still, because there's a recent case which has come. So this is what I wanted to emphasize, that sometimes we can get this type of a picture also. So my take-home message is, all this edema is not papilledema. We have to be very careful when we call it as a papilledema. It has to be associated with increase in the intracranial pressure. So accurately diagnosing optic disc and grading its severity and recognizing its cause is very important, because optic disc edema as such is not a diagnosis. You have to find out what is the cause for it, because you are not only dealing with some life-threatening conditions, but also you are also dealing with the vision loss, which can be affected, especially in IH. You are giving with the neurologist, you're helping them to whether you will be intervening and how much of the dose of Diamox which will be given to them has to be correlated and done. So detailed history taking, visual symptoms, ocular fundus examination and imaging will guide you for accurate diagnosis. A collaboration is a must with a neurologist and a neurosurgeon for all these cases. So I just finish it with a poll to the, because for everything the PGs has to take it. So if you look at this, what are we dealing with? This fundus picture, are we dealing with a malignant hypertension, or are we dealing with a CRVO, optic neuritis, or neuroretinitis? So thank you very much.
Thank you, ma'am, for that lovely talk with all the images as well as the cases there that were discussed. I would like to specially point out your very nice flowchart approach, especially to unilateral and bilateral disc edema, which is the most confusing approach for a PG student, I would say. And also the fact that you pointed out that it is actually a sign and not a diagnosis by itself. And we need to go ahead and sort of test more with basics up going up to neuroimaging, and then it could be a life-threatening thing as well. So one question I had for you and our other panelists, if we get a patient who has sort of a sectoral disc edema, is showing you altitudinal field defects, in like clinically you're suspecting that it may be NAION, the blood tests have not yet come. So would you wait for the blood test, or would you want to jump in and do neuroimaging on an urgent basis in such a patient?
I think we can still wait and for the blood test to come. Let it be open to the panelists, let them give their opinion. That will be better.
Dr. Goyal, sir, your opinion on this, sir?
Actually, in NAION, so we should not hurry up for the imaging. And if there is NAION, even if we do imaging, it may not be any contributory. But in NAION, usually the vision is the most important thing. If there is a sudden loss of vision or in the visual field, so that is sufficient for you to start the treatment itself. Now the treatment is what treatment in NAIUN? NAIUN is a poor visual prognostic condition. So even if you treat, there is a improvement, but it will be only slight. So one of the things which is given, if you are doing OCT in these cases, if you find any edema in the retinal layers, so then especially in the nerve fiber layer or in the ganglion cell layer, so if there is a cheese-like appearance, so then of course you may expect a better visual outcome because that edema will go with the treatment. And you might get a partial improvement. But the majority of the cases in AIUN, so the patients, they do not improve. So secondly, in NAIUN, especially if it is inflammatory, then the question is how much steroid should be given and up to how long. And you cannot go on giving steroids if it is an inflammatory AIUN. So for lifelong, because the steroids, they have their own side effects. So one of the things which is mentioned, which is followed up, is that you do CRP and ESR. When the CRP and ESR, they come normal, then you can stop the steroids in between. And then again, you go on doing the same thing subsequently. If the CRP and ESR goes high, then again you start. So that there is a breathing time in between, so that you may not get the side effects of these steroids. So that is another thing. So that's all about this condition. And if anything is to be added by other panelists, thank you.
Madhavi, what blood test were you talking about? That meanwhile we await the blood test for the diagnosis of this. Yeah.
I mean, ma'am, if you have a patient who walks into your OPD looking clinically like NAION, but is not a known systemic disease, like he is not a known diabetic or hyperlipidemia or homocysteine, any of those conditions which we consider. So while we order the blood panel, should we wait for the reports or just go ahead and do a neuroimaging as well, like a first-time diabetic patient, that sort of thing?
In ischemic optic neuropathy, I think more than the blood test, it's the disc at risk. The answer about the, it being an ischemic optic neuropathy lies in the eye itself. You kind of looking at the disc appearance, the other eye disc, the same disc. If it's a small disc at risk, it's a very colorful disc. It's parts of it are, there's a little bit of hemorrhage, there's a little bit of, exudation. There is, as Dr. Goyal said, there is fluid at macula on OCT. And in the OCT, one more thing wanted to add, the GCC layer gets affected as early as 2 days. One paper has suggested that. Very early, you'll see, if the patient is presented even a week, within a week, you will see GCC changes. A lot of pins are there in the eye itself. And the blood test kind of, add on to it. That is for the non-arthritic. For the arthritic, it's a totally different thing. It's the systemic, the age at which the patient is presenting. And so a lot of clues are there in the patient. But if you say that, the patient, normal patient, not a known diabetic, hypertensive, and has come with just subtle disc edema. The disc is not colorful, it's not cupped.
Right.
Yeah, it might be an altitudinal defect, and you might get hyperlipidemia on your blood test. You might get hyperhomocysteinemia. But I would like to image that patient to rule out, optic neuritis. So I think a lot of inflammation is there in the eye itself.
Okay, yeah, that helps and kind of answers my question too. Thank you. So one more question was that when ma'am discussed a lot about pseudo-disc edema as well. So of course, clinically, we do tend to find out whether it's a drusen, but many a times it could be a buried drusen. So what would be your next line of approach for such a patient? Like if we have all the options available, would we do an autofluorescence or an OCT or a B scan? Which of these three would be like, if you have to choose one best one, what would be your choice?
I think OCT, for a drusen, OCT is kind of, that consortium has come and very clear, this thing, that's the sensitivity is quite high. You can pick up the drusen. Not only pick up the drusen, you can rule out other things also. You can, on OCT, you get a lot of information about it being some other disease, associated disease. You can, as said, you can pick up the fluid, you can look at the, if there is in a chronic kind of, question between pseudo-papilledema, papilledema, sometimes, peripapillary CNVMs are there. You can get a lot of information. So if I have to choose one investigation, I go with OCT, I think, because you can directly visualize the drusen. Then there are other things like forms. There are horizontal hyper-reflective lines. Those are not actual drusen. Those are probably precursors of drusen. So if you see those kind of things, also, that, you're dealing with
pseudo-dyschedema.
Yeah, and with spectral, with spectralis, you can get your autofluorescence on the
same
OCT itself.
Madam, can I ask you one question? What about OCT angio? They're talking about, can the OCT angio help to detect this optic disc drusen? Because early studies are going on. So they are telling that capillary network which decreases. So have you any idea to throw about it? Because still they are not, there is no confirmation about it.
Yeah, so OCT angiography, in basically what information it gives. On FFA, we can't look at the peripapillary capillary network. In OCT angiography, that's the only technology where these fine blood vessels can be picked up. Now, where the problem comes is in acute disc edema, you can't really visualize these things. So if the disc is edematous in acute stage, the actual information, getting the actual information, that's where we are limited. But yeah, in cases where the attack has occurred, this layer, the vascular network, the thickness kind of correlates with the RNFL thickness. So those dropout areas later on, that kind of correlates with the thinning and the loss of exons that's occurring. But in acute stage, not really. In optic nerve head drusen, again, the areas where, the blood supply is getting compromised, the capillary or the RNFL exonal loss is occurring due to the drusen, you can pick that up. But not really the pattern. For the picking up the drusen, you need the enhanced depth imaging, as mentioned previously, to pick up the drusen. Another thing is in ischemic optic neuropathy. This is something that we are looking at. I'm trying to get it published. It's not published as yet. If you do OCT angiography, you can see, we've all read up about luxury perfusion, right? So in ischemic optic neuropathy, a part of the optic disc, that optic nerve head has an infarct and does not have blood supply. The other area gets, compensatory increase in the blood supply. So that can be picked up. That happens only in ischemic optic neuropathy, and it can be picked up on OCT-A. So that flush you can see. So that I've used in a few cases to kind of confirm whether, it's ischemic optic neuropathy. I'm trying to get that published. We'll need a little more numbers. And yeah, maybe, so I'll say that in OCT angiography, probably looking at the pattern of where these the blood vessels, the blood supply is, which areas it's, and also you can actually get the flux index. You can actually get some objective data, So you have to, probably artificial intelligence will have a lot of role here. You have to, in certain diseases, you have to do that and see, study the pattern. So right now in the research stage, but I don't know in clinics, I think Dr. Virender has done a lot of work on OCT angiography. He might have something to
Thank you, Dr. Shika. I think you have very beautifully said that about the role of the EDI, OCT, and the consortium guidelines. One point about adding the role of OCT in picking up the drusen is that even though classically if a PG is asked what are the investigations, we can start with autofluorescence, B scan, but we should remember that they will be more sensitive in picking up the calcified drusen. But the uncalcified drusens, they will be less sensitive. You might see an optic disc elevation there, but then uh, the role of EDA OCT would be the highest, and it can help differentiate the other things which you already highlighted. That was one point I wanted to add. The OCT angio, we have been trying to do in our patients, and specifically given the previous situation which Dr. Bijlani was asking about a patient coming up with suspected NAIMN, would we send for a neuroimaging? We are hardly likely to find anything over there, but OCT angiography is available in the clinic. And with good application, we can pick up the areas of the capillary dropout. If there are specific capillary dropouts focusing with they're matching with the corresponding with the field effects, then it can really help contribute to strengthening our diagnosis. This is one additional investigation that we can do before we send out the patients. Classically, if we see the neuro-ophthalmology specialists across the globe, they say that there is no role of neuroimaging in NAIMN. But if there's a doubt, patient is doubtful without other risk factors or not matching the picture, then definitely MRI orbits with contrast, including brain, would be helpful. Thank you.
Thank you, sir, and thank you, ma'am, and everyone else for your inputs on this. Thank you so much, Dr. Sucheta, for your wonderful presentation. With this, I would like to move on to our final speaker
One
for
more
today.
thing. Excuse me, just one more thing.
Yes, sir.
That in idiopathic intracranial hypertension, so sometimes we get unilateral edema, disc edema, although it's a bilateral condition, but sometimes we get unilateral disc edema also. Because if there is a fibrosis of the optic nerve sheath on the other side, so the patient will have unilateral disc edema in these cases.
Yes, Dr. Goyal.
Okay.
Maybe Dr. Sujeta had put up in her slide the causes of unilateral disc edema, but for all of us to just recapitulate for the benefit of PGs, we can start with ruling out pseudopapillary edema, optic nerve causes, orbital causes, and retinal causes, which are the more likely causes of unilateral disc edema. And rarely it can be a sign of a systemic asymmetric disc edema in CNS pathology, such as raised ICP, IAH, or a systemic disease. So that would be the last in the definition.
And even if there is asymmetric edema, so if the edema is more on one side, that does not give you laterality of the lesion.
Yes, sir. That's a very well put point. Thank you so much for that addition to our entire list of disc edema topics. Thank you once again, ma'am, for your topic on your lecture on disc edema. We move on to our fourth speaker for today, Dr. Gohar Ahmed, who's joining us from Srinagar. Sir, could you unmute yourself and share your slides, please? Dr. Ahmed. Yes. Dr. Ahmed is an eminent ophthalmologist at Florence Hospital in Srinagar and has spent over 4 decades dedicated to improving vision and making a profound impact in healthcare in the region. He has studied from Agra and Saudi Arabia and has been a consultant in Saudi Arabia as well as Srinagar and has over 45 years of experience in ophthalmology. He is an influencer and icon on Curify and editor-in-chief of the International Journal of Scientific Research. Thank you, sir, for joining us today. Sir will be speaking to us about golden hour syndrome. Sir, could you please share your presentation?
Just wait. Can you hear me?
Yes, sir. Very well.
The thing is that I think there was a problem in this slides, and well, this case of this Goldhar syndrome is more of actually this. Can you hear me?
Yes, sir.
So
We
I
can't
think
see your presentations.
Mr. Sunil had a problem of uploading my slides, so I will try to be more of an audio. See that this over the past 10 years, this is an entity of a Goldhar syndrome. It is not a very common, it's uncommon, but over the past 10 years, I have seen about uh, 8 or 10 cases. So the credit of this Goldhar syndrome goes to an Austrian ophthalmologist who was the first in the year 1850 uh, by the name of Morris Goldhar, who presented this entity after his name as a syndrome which is sort of characterized by congenital limbal dermide with congenital associated presence of a periodical skin tag and appendage. Sometimes the presence of a squint, an ophthalmos, coloboma of upper eyelid, iris retina, astigmatism, microphthalmos, and biliary syndrome may be associated. Well, the most of these cases, it is mostly audio. Uh, it will not be a sort of a common thing that we will just put the slides. I tried, I had a full list of slides, but Mr. Sunil was not able to upload it. So the Goldhar syndrome is also termed as ocular auricular vertebral syndrome dysplasia or a craniofacial syndrome, which involves the head, neck, ear, nose, mandible, and soft palate, manifesting in the form of high arched palate, facial asymmetry, hair lip palate. 80 to 80% cases of the Goldhar syndrome are normal from the visual, mental, memory, and intelligence point of view. It's only in the 15 to 20% cases of the Goldhar syndrome that you get an additional congenital anomalies which are in the form of the defects in the kidney, like you may get hydronephrosis, double ureter, defects in the spine, limbs, congenital heart, underlying orbital involvement, dental anomalies, and hearing defect, impairment of memory, intelligence, and mental faculty, seventh nerve involvement, Down's retraction syndrome, and seventh nerve involvement. There is a unilateral aplasia of the trigeminal nuclei, so you get a trigeminal anesthesia. So you have to work up these cases as to do ultrasound kidney to rule out this double ureter and hydronephrosis, supine X-ray and the limbs X-ray, echocardiography, MRI orbits to rule out under orbital involvement, dental anomaly examination, that full dental examination. For hearing defect, you have to do audiometry, EEG. As far as the scenario of the limbal dermis is concerned, they are usually unilateral, can be bilateral, but that's very rare. The infotemporal site is the commonest, Its prevalence is 1 in 10,000, 1 in 50,000, and male-female ratio is 3:2. So the limbal dermites are classified according to the involvement of the cornea. Grade 1 is epithelial involvement, grade 2 is descemet membrane, grade 3 is the involvement of the whole of the anterior segment. So whenever you get a limbal dermate congenital, you have to look for the association of a preauricular skin tag or an appendage or presence of a squint and ophthalmos coloboma of the iris, refractive error, microphthalmos, biliary syndrome, other anomalies like facial asymmetry, high arched palate, microphthalmos, and other entities. Now, the thing is that you have to work up the cases by doing an ultrasound to do the X-ray spine limbs. Now, something about this Goldhar. Goldhar was an Austrian ophthalmologist. The other ophthalmologists of the Vienna are outstanding, like Putscher retinopathy. You have got this nodules of the leprosy of the iris, Pillet's nodules of leprosy, Fuchs corneal dystrophy, and this Putscher retinopathy, which occurs after acute pancreatitis, idiopathic thrombocytopenic purpura, bone marrow depression, connective tissue disorders, after air, fat, and this fat embolism to the fracture of the long bones, and head abdominal and thoracic injuries, which leads to increased intracranial thoracic pressure. Bush retinopathy is a very complicated traumatic retinal angiopathy. All these people which I have told you, the other great Australian ophthalmologist is Krukenberg's pigmentary glaucoma. All these things are the eminent ophthalmologists of the Vienna, Austria, and Goldhar is one of them. Now, I have, over the past 10 years, seen a few cases of the Goldhar syndrome, and one of them, which I presented in the European Journal of Ophthalmology, the pediatrics, was the parents had observed in a 3 years old male child infratemporal side limbal dermide, which was associated with the periauricle skin tag. And it was not a first cousin marriage parents. And the limbal dermide basically was grade 1. It had not involved the pupillary area to threaten the vision. So such patients who have got a grade 1 and do not have the other associated congenital anomalies, which I have enumerated by investigations, need only the parental counseling and observation. However, if the parent limbal dermide involves the pupillar area to threaten the vision, then the surgery is both visual and the cosmetic. And the surgical modalities which we have got is lemur keratoplasty, autograft, skin cell graft, and amendment graft. The best thing which we have is a semile lenticule, tattooing, and fibrin glue. You excise, put the limbal dermide, tattoo it to get the normal coloration, put a lenticule in situ by fibrin glue. This technique, since we do not use any sutures, the postoperative astigmatism and pain is less. We have got a Goldhar syndrome support groups. There are 17 families of the Goldhars which are seen in Greece. Children born in the Middle East during Gulf War, born in different military hospitals, had a high incidence of Goldhar. Mittal et al. In the Journal of Ophthalmology, 1968, reported 3 cases of optic nerve drusiness associated. So, in nutshell, I would have liked to show some of the slides, but actually, it's not that important because this is a rare entity. And over the past 10 years, whatever the cases, 4 or 5 cases have seen, have been luckily in the group of 80 to 85% cases where there have not been the associated other congenital anomalies. The other congenital anomalies which are there, which I have enumerated, are believed to be due to the incomplete development of the first and second brachial arch due to defect in the genes, autosomal dominant, or it may be because of the gestational metal diabetes, or it may be because of the intentional or unintentional intake of thalidomide, cocaine, antibiotics, or it may be an exposure to herpes zoster, herpes simplex, setum inclusion, and toxoplasmosis. So you have got Goldhar support group, which I have told you, 17 families in Greece. So in nutshell, to enumerate Goldhar syndrome, a rare entity, not uncommon, is characterized by congenital dermide with associated presence of the periauricle skin tag and other rare anomalies. So whenever you have got a congenital dermide, please look for all those things. When you look for all those things, like it becomes a Goldhar syndrome. But at the end, you have to also do the investigations like that these patients in the 50 to 20% group may not have the associated lesions like cardiovascular, kidney, underoperative dental anomalies. Then when they have got the other anomalies like periauricle skin tag, hair lip cleft plate, that is at that particular time, the plastic surgery comes into. That's all which I have to.
Thank you, sir. Thank you so much. Unfortunately, there was a glitch with the slides and we could not share them. But it has been a
Those
very
slides
enlightening
actually,
talk.
basically, Mr. Sunil did a lot. They would only show the
Yes, he did.
infratemporal side limbal dermide. Then they would show the hair lip cleft plate and nothing more than that. Most of the Goldhar syndrome is mostly the tox. And luckily, over the past from 2013 to 2025, I have seen 5 cases. And luckily, they were not having the other. Recently, I told you the limbal dermide congenital is usually unilateral. Bilateral is very rare, but in third order ophthalmic conference, which was held in Dehradun, there was a presenter who presented a case which had got a very rare bilateral congenital limbal dermite. I told you the bilateral congenital dermite is very, very rare, but that had a Gold-Horse syndrome with a bilateral congenital limbal dermite.
Thank you. Thank you, sir. I would like to ask our other panelists about their experience in golden hour syndrome and how they have managed it in their institutes.
One of the things which Dr. Ahmad has not mentioned is subconjunctival dermolipoma. So in golden hour syndrome, in addition to limbal dermoid, you will get subconjunctival dermolipoma in the upper temporal quadrant. So that also is important in these cases.
No, sir. I will tell you one thing. Which literature shows dermal lipoma in golden harms? Dermal lipoma is a condition where you have got basically three L's: levator, lateral, lacrimal gland. When you have a dermal lipoma, it looks simple. Okay, then you have to be very careful. Most of the dermal lipoma which I have seen, I have left because I saw one case when I was in the Middle East. A resident removed a dermal lipoma. He cut the lateral rectus. He cut the lacrimal gland. Which literature shows that the golden horse syndrome is associated with dermal lipoma?
I think clinically also we have seen plenty of cases.
No. I'm sorry, I'm not. The thing is, golden horse syndrome is limbal dermite with a preocclusal tag. When you have a limbal dermite, you have to look for the other things. Dermal lipoma is something else. Dermal lipoma, okay, I can agree. One of the things with the dermal lipoma is on the lateral side. There are three L's: lacrimal gland, lateral rectus, and levator pulpus superioris. When you are touching the dermal lipoma, it is not a limbal. Dermal lipoma, be careful that you do not cut the levator, you do not touch the lateral rectus, you do not touch the lacrimal gland.
That is true.
You showed me the reference of dermal lipoma associated. Yes, the golden horse syndrome is associated with Down's syndrome, other anomalies, trigeminal anesthesia, seventh nerve involvement, hair lift, cleft plate. Okay, the 50 to 20% cases, the defects in the kidney, double ureter, hydronephrosis. Where is the reference of dermal lipoma in golden horse? Show me.
No, I clinically I have seen plenty of cases. I don't know why you could miss that thing, but you say that there is no literature.
Over the past 10 years, I have worked on the golden horse syndrome. I have never seen a case of a dermal associated. Have you seen the reference of Mitchell et al. In 1968? Have you seen the cases of 3 cases he terminated, 3 cases of Drusins associated with golden horse syndrome? Never dermal lipoma?
No, I think, sir, from a this is from a PG standpoint, they need to know the standard parts, or I would say constituents of a golden hour syndrome. That is the more important thing.
I could add it because over the past 10 or 12 years, I am still a student. I am not a person that I will just sort of argue like that. It could be an addition to me if I will see that there is a association of a dermal lipoma. In one of the cases, I was not even knowing that there is a Down's syndrome associated with this thing. It added to my knowledge a couple of years before. If the dermal lipoma has an association with golden horse syndrome, you show me the reference.
I would like to thank you all for all your inputs on this and on golden hour syndrome as well, which is a rare topic but a must know for all PGs and fellows, I would say. And with that, anything else anybody else would like to add on any of the topics we have discussed this morning?
So
I think we've had, yes, sir.
One thing, the vintage edema, one of the things which has been mentioned in the textbooks also. So that is a condition in which there is no swelling of the disc, but if there is a progressive optic atrophy in cases of subsequent atrophy, if the intraocular pressure, if the intracranial pressure rises, so as we know that the dead optic nerve cells, they don't swell. So the nerve fibers, they don't swell. So in these cases, if there is a persistent headache in spite with the increased intracranial pressure, so that is a condition which is called vintage edema. That is a dangerous edema. So that also condition should be kept in mind.
I have a
Thank you.
question.
Thank you, sir, for that.
Can I ask a question?
Yeah.
Yes, sir.
I'm sorry, I might have missed that. But in a case of a non-arteritic ischemic optic neuropathy, I mean, what is the role of systemic steroids? I mean, pulse steroids like sodium metformin.
Actually, in non-arteritic ischemic optic neuropathy, of course, it's a controversial thing because in non-arteritic in ischemic optic neuropathy, if you don't give anything, even then these patients they will get relieved. But if you see the Son Singh Harry's management of cases of non-arteritic ischemic optic neuropathy, he has mentioned that the cases which were not given and the cases which were given steroids, even in NAION, so he has shown that there is a significant improvement, and the patient also feels better after steroids. Maybe a subjective feeling of betterment. In these cases, if the patient is having a severe loss of vision and you say that there is no treatment to be given, the patient will not be happy also, even otherwise also. So now the thing is whether to give anything or not to give anything. So I always prefer giving steroids at least 40 milligram of prednisolone in an adult case. We give steroids and we see that the visual acuity improving faster in these cases as compared to those who are not given steroids. I think even Digvijay Singh also has mentioned in his article, he has published a series of cases in NAION.
Yes, so we did do it in non-diabetics, and we did find that there was some, little faster improvement, and some of the parameters at the end, those subclinical, were showing improvement relative to not giving steroids. But again, there is equivocal literature which says there's no difference. So really, it's an individualized condition, sir.
Yeah.
Okay. Thank you. Thank you so much, all of you, for sparing time on a Sunday morning and enlightening all our PGs and fellows from across the nation. Special thank you to all our speakers for their excellent presentations covering the clinical and investigative aspect of neuro-ophthalmology today, to all our panelists for sparing time with us, to AIOS for giving us this platform. Thank you so much, and may all of you all have a lovely Sunday. Thank you.
Thank you.
Thank you.
Thank you.
Thanks.
Thank you, everyone. Have a great day.